Good morning, everyone. As we do every Tuesday, Commissioner Pichek will be here today to present our latest data and modeling. What you'll see is that for the second straight week, our case growth and positivity rate continues to drop. As well, we're seeing a slight decline in our regional cases too, which are both promising signs. However, we know it's too early to see the impact of what holiday travel or larger gatherings than we had suggested will have, so we'll continue to watch to see what happens over the next few weeks as the number of cases may go back up after the holidays. Our hope, although, is that we'll continue seeing a plateau or maybe even a decline in Vermont and throughout the region, but admittedly, we're holding our breath a bit. In the meantime, we need folks to continue to pay attention and use common sense, which means avoiding unnecessary gatherings or traveling out of state, wearing a mask, and keeping your distance from others. We've now been at this for almost 10 months, and I know how frustrating it is to still be facing restrictions, having to think about your every move, and having to be extra cautious. But we know these steps are the best way to help limit the spread of the virus, while we wait for more vaccines and can get the majority of Vermonters vaccinated. This will take some time, but we're on the path to being able to better protect our most vulnerable from the risks of this virus and move closer to the end of the tunnel. As you know, the rollout of the COVID vaccine continues across the country, and in Vermont, we've now vaccinated almost 10,000 Vermonters. Our program has been moving forward as planned, but as with everything in this pandemic, we're always looking for ways to do it better. Our vaccination teams are meeting multiple times a day, keeping track of what we're getting in, what's going out, and the progress we're making to ensure we meet our top goal of preventing as many deaths as possible. The team has identified ways to improve our reporting so the public has a better sense of our progress, planning for the next phase of the rollout, and importantly, they're working with the federal government for more flexibility to distribute to long-term care facilities. Secretary Smith will be sharing details on this work shortly. Throughout this crisis, protecting the most vulnerable has been our top priority. We've seen the devastation this virus brings to long-term care facilities, so I appreciate the work of this team to find ways within the federal guidelines to get vaccines to both residents and staff as quickly as we possibly can. This is probably the most important step in this process and should give us all hope for the future. With that, I'll turn it over to Secretary Smith to share more on these efforts.
Thank you very much, Governor. As the Governor mentioned, we have vaccinated approximately 9,800 Vermonters so far. This is broken down by the following: healthcare workers 8,000, EMS 900, long-term care through the federal pharmacy program is 900, although I would caution that the pharmacies have about 72 hours to report the results to the federal government, and that is a significant lag in these numbers. In fact, by January 8th, we should be finished with providing the first dose of vaccine to all but one of the residents of skilled nursing facilities, where the frailest of the elderly often reside. As of today, residents at 19 of the 37 skilled nursing facilities have received their first dose of the vaccine. All but one of these facilities should receive their second dose by the end of January, and we are currently working with the pharmacies and the federal government to accelerate the first dose vaccine at other long-term care facilities. As the Governor mentioned, these sort of facilities are residential care and assisted living facilities. In fact, this morning, Kinney's, one of the 3 federal pharmacy participants in Vermont, said they are willing and will be willing to accelerate the vaccinations in residential care and assisted living facilities to be completed by mid-January. Walgreens has indicated as well that they're interested in accelerating the program. In addition, patient-facing healthcare workers are being vaccinated as well. In all, we have been allocated nearly 32,000 doses of the vaccine, of which 24.2%, and if you could go to slide 2, thank you, has been shipped to hospitals or our depot, and the remainder allocated to the federal pharmacy program. As of yesterday, 14.8% of Phase 1A has been given the first dose, and 1.4% of the total eligible Vermonters, population in Vermont for the vaccine has received the first dose. Again, I would caution that long-term care numbers are lagging. We'll have a better reporting mechanism the next time we meet. By the end of January, though, all of Phase 1 should have received at least the first dose, with many having received the second dose of the vaccine, including most of the skilled nursing facilities in Vermont. So what comes next is the question that we often get. Let me give you a preview of the details to come later. The completion of 1A marks the beginning of the mass vaccination program. The mass vax program will have 4 locations where Vermonters can go to be vaccinated. These are your primary care provider, pharmacies, health department district office sites. There are 12 of them, and capable of handling 300 people each, twice a week, or 7,200 vaccinations a week. And then, of course, mass vaccine sites set up or in conjunction with our testing sites that we have at multiple locations, up to 19 here in Vermont. All of them will be in service when enough vaccine is available. Vaccines will be prioritized and given based on age, because the older you are, the more vulnerable you are to COVID-19, and it meets our prime objective, which is protecting lives. It's the easiest way to administer vaccines, and it's the easiest for the public to understand. There will be age bands established when you will be eligible to be vaccinated. For example, 75 plus will be the first to get vaccine after the completion of 1A, then 70 and over, and then 65 and older, and so on and so forth. Underlying conditions will be a priority no matter what age, and those conditions will be well defined. We are also working on how those that may be disadvantaged fall into these priority groupings. We recognize that some individuals may be disadvantaged and have suffered from health inequities. Our implementation planning will seek to mitigate these inequities. We will consider what may come from national and state advisory panels, but what we are trying to do is to design a system that is easily implemented, easily understood, and prioritizes our fundamental goal, protecting lives. Definitions such as essential worker or frontline workers often cause confusion and unnecessary divisiveness, and doesn't put enough emphasis on our primary goal of saving lives. We also have put in place, as the governor mentioned, a vaccine task force to ensure that the objectives of our distribution system are met. The vaccine task force is made up of representatives of the Agency of Human Services, Department of Health, Department of Public Safety, Vermont National Guard, and the Agency of Digital Services. As the governor mentioned, they meet multiple times a day, with a major meeting once a day at least. In addition, the governor requires his senior leadership team to keep him apprised daily regarding the progress of the vaccination program. This includes reviewing daily metrics to inform both the governor and the public on our progress in our vaccination efforts. There will be more to report in the coming days and weeks, especially on the vaccination program dealing with residential care and assisted living, but we thought it was important to give Vermonters a preview of things to come, especially in terms of when we're talking about mass vaccination. With that, I'll turn it over to Commissioner Pieciak.
Thank you, Secretary Smith, and good morning, everyone. As 2020 draws to a close, the week offers each of us an opportunity to reflect on what has been a long and painful year. It's an opportunity for each of us to remember the hurt that so many families across our country and in our state are feeling who have lost loved ones to this awful virus, and for us to keep them in our thoughts. It's an opportunity also to remember the many sacrifices and hardships Vermonters have endured, from canceled graduations and games to job losses and shuttered businesses. Finally, let us also take a moment to appreciate our special state as well. The resiliency, the compassion that you all have shown, the commitment to your neighbors and to the common good, and your willingness to make sacrifices in the near term for our state's long-term success. As terrible as 2020 has been, Vermonters have many reasons to look back on the year with pride and to look forward with optimism for the year ahead. A quick note about data that we'll present over the holiday period. Like Thanksgiving, we can expect to see some variances in state and national data. For example, asymptomatic testing is likely to be reduced during this period. Further, some states may have less testing available, and some may not report their data on a regular pattern over the holidays. We need to be mindful of this over the next 2 weeks. This past week, Vermont recorded its 7,000th case since the start of the pandemic. However, to put this into some helpful perspective, Maine has recorded more cases than that in just the past 3 weeks, and New Hampshire just the past 2 weeks. So Vermont continues to maintain a very low level case count, both in the aggregate and on a per capita basis. As we close out the year, our case growth is also on a favorable trend, with our 7-day average decreasing by 28% over the past 20 days. Similarly, we are also seeing clear downward trends in our active case numbers. With fewer cases circulating in our communities are becoming safer over time. Our positivity rate also provides another favorable trend, as it's been decreasing and staying low throughout the later part of December. There's also reason for optimism looking at our hospitalization rates, which have remained steady and recently are trending lower. Regarding COVID-19 deaths, we have unfortunately seen a significant increase here. In fact, December will be the deadliest month of the pandemic for Vermont. 85% of our deaths so far this month were connected to a long-term care facility, again highlighting just how critical it is to get this population vaccinated. Regarding long-term care facilities, there was one new outbreak this past week, and currently there are 513 cases associated with an active outbreak in a long-term care facility. We do, however, have some optimism here as well. This week saw the fewest number of new cases in a long-term care facility since we restarted reporting on this number late last month, and we can all hope that this will continue. Turning to our Vermont forecast, we see a projected case trend that is better than any recent forecasts we have presented, anticipating that cases will remain relatively flat over the next 4 weeks, an improvement of a projected 34% increase just last week and 70% the week before that. And even with this improved forecast, I am confident Vermonters will be able to beat this projected outcome. This week, the Northeast again saw a decrease in cases, albeit slightly, reporting just under 146,000 cases, or about a 0.5% decrease compared to last week. This is the second straight week that we saw a decrease in regional cases. A good sign, although as the governor mentioned, we need more time to evaluate the data and the impact from the holiday season. Looking at the regional heat map, we see that Vermont continues to stand out as the state with the fewest active cases in the region. Again, there are over 500 counties in this map region, and of the 10 counties with the lowest active case counts, 8 of those counties continue to be in Vermont, with counties like Washington and Orange, who were just recently struggling, now leading the region. As we did following Thanksgiving, we'll also be closely monitoring our mobility data to see what might lie ahead. First, an encouraging sign, we see that air travel was down considerably compared to last year, both nationally and locally. Regarding our mobility data, we currently have data through Christmas Eve, which is indicating a sharp downward decrease in travel compared to last year. However, as you can see from the chart, even in this early preview, visitors surpassed the number of visitors we saw at Thanksgiving for this current year. So we'll need to continue to watch this closely and remind Vermonters and our guests to follow Vermont's health guidance closely. Finally, regarding vaccinations, the CDC is now reporting that over 2 million Americans have received their initial dose of the COVID-19 vaccine. A long way to go to the 20 to 22 million healthcare workers and long-term care residents that require vaccination, but certainly a strong start. And for the first time, we're also publishing a regional vaccination map to track the progress regionally, like we've done with the travel and heat maps. Each of these states are early in the progress that they're making on the vaccination front, and at this point, publicly available data is not always timely, and it's not always uniform, but we intend to update and improve upon this as data becomes more readily available. And you'll see that just from today's update, Vermont is one of the leaders in terms of the percent vaccinated within the region. Last, we continue to see that Vermonters are getting their flu vaccine at a higher rate when compared to the same time last year. We are about 10% ahead of where we stood last year at this time and 82% toward our goal. So if you haven't done so already, now is the perfect time to stop by a local pharmacy and to get your shot. And with that, I wish everyone a Happy New Year, and we'll turn it over to Dr. Levine.
Good morning, and thank you, Commissioner Vichek. To start, I want to personally acknowledge and thank those health department staff who worked over the holiday weekend. Our epidemiologists, contact tracers, lab technicians, public health nurses, support staff, and so many others across the state. Public health never sleeps, and this year in particular, I thank you all for how you go above and beyond. Today we're reporting 82 new cases and 1 additional death, bringing to 10 the number who have died in the past 5 days. Our deepest sympathies go out to their families and friends. There are currently 31 patients hospitalized, with 6 in the ICU. Our epidemiology teams are investigating 41 outbreaks and 224 active situations. At last Thursday's press briefing, I was asked about outbreaks. Of the 41 outbreaks, 14 are in long-term care facilities. The majority of those, which have sufficient numbers, are represented on the slide. I will note that though some of the numbers seem large, we do not see them increasing rapidly in the past week. 12 involve school or child care. 5 are at work sites, 6 in health or home care, and 3 are related to private events or social gatherings, and 1 is categorized as other. And finally, based on our testing results, the state's 7-day positivity rate remains low at 2%. Regarding the 3 outbreaks related to private events or social gatherings, 1 has been discussed here previously and just has not closed out yet because it needs to go through the sufficient number of incubation periods of the virus, and that was at the Vermont Police Academy. The second was in a funeral gathering, and the third is in Bennington regarding a social gathering of several families. Social gathering that exceeded the guidance that we've been providing consistently throughout the last month or two. For many, especially those involved in healthcare, every holiday season is a mix of joy and sadness. This year is especially so. We have unfortunately just come through a weekend that saw the losses I just mentioned, and the end of this trying year will mark at least 130 lives taken from us by this virus. My only other slide here shows the breakdown by age of the Vermonters who have died due to COVID as of Sunday evening. You can see from the caption that 70%, or 69 of these deaths, are among residents of long-term care facilities. That statistic alone reveals why we have agreed that these Vermonters belong in the highest priority group, 1A. I'm going to come back to the slide in a second, but I want to just talk about some of the primary factors that contribute to this tragic impact that I just mentioned. First and foremost is that the levels of illness and deaths among Vermont's long-term care facilities are usually not due to problems at these facilities, nor a reflection on the staff or administrators. Instead, they reflect the fact that the virus is circulating in our communities at levels far higher than during the summer and early fall, which means exposures happen. We've learned in the past year that people who have been exposed and carry the virus may show no symptoms, and therefore, unless tested, would not know they're infected or infectious. Unfortunately, once the virus makes its way into a facility, it meets people who are among the most subject to severe illness. People who are older, have chronic and debilitating health conditions, and who are largely confined to their living spaces. These are also people who have frequently made end-of-life decisions, such as a do not resuscitate order or an advance directive, expressing their desire to die where they are and what peace they may have. These are all factors that lead to higher rates of illness and death among residents and patients compared to the general population across all age groups. Now back to this slide. We've totaled more deaths in the last 3 months of the pandemic than we did in the first 7. However, as you can see, the impact on those age 80 and older is higher these last 3 months with the blue bar. But the slide also tells us that 30% of deaths occur in people living in the community. And as you can see by the age breakdown, these deaths are almost exclusively among people age 60 and older. Only 7 of the 129 deaths were among Vermonters ages 30 to 59. One more important fact. 40% of people with COVID have a pre-existing chronic condition. Some have 2 or more conditions. And a higher percentage of COVID patients with pre-existing conditions have been hospitalized compared to those without. 9% versus 1%. And of course, the highest risk aligns these conditions with increased age. All of this informs our governor's and COVID-19 leadership team's decision-making concerning next priority groups for vaccination. A focus on reducing hospitalizations and saving the lives of those at greatest risk, people who are in the oldest age bands and people with chronic conditions. And there are over 400,000 Vermonters who, when you survey them, would tell you they fit the criteria of age over 65 and or a chronic condition. In case you're wondering what comprises a high-risk chronic condition, they're kind of obvious and not surprising. Heart conditions, emphysema, type 2 diabetes, cancer, chronic kidney disease, and anything that compromises a person's immune system, like a solid organ transplant. Implementing the state's vaccination plan is being done in phases. Immunization effort for Group 1A individuals, including high-risk healthcare workers and long-term care facility residents, as you've just heard from Secretary Smith, is proceeding well. Tomorrow, the Vaccine Implementation Advisory Group will meet again to prepare its recommendations for the next phase. The advisory group's recommendation will be submitted to Governor Scott and the immunization leadership team for consideration. Our guiding North Star in this endeavor is, as you've heard, to prevent the most deaths. The complex work of prioritization is essential in these early stages. It must be done with careful consideration to ensure there's equitable and systematic access as the amount of vaccine coming into Vermont increases. With each shot, we are that much closer to reducing the risk of exposure to where we can begin a return to a state closer to normalcy. Throughout these next months, while we're still in the depths of the pandemic, we must all keep a steady hand on the wheel. It's too early to know if we will see an increase or not in cases following the holidays, but the projections do look favorable. The more people who follow the guidance for travel and limited gatherings, the better the odds we will not see a spike. The same will go for New Year's, a day that will mark the end of 2020, a day many of us are anxious to celebrate and begin our look towards brighter days ahead. So I finish, as I often do, with an appeal to all of us to make it happen. Follow the guidance to limit gatherings, and if you must do so, to no more than one household outside of your own. Reduce your risk of exposure. Consider getting a test following any get-togethers. Make sure, if you are in the older age group or with chronic diseases, you avoid having such multi-household gatherings. Keep in mind this simple guidance: masks on faces, 6-foot spaces, uncrowded places. Now I'll turn it back to the governor.
Thank you, Commissioner Levine. We'll now open it up to questions.
Start with Calvin.
Thank you, Governor. So, I understand, maybe this is a question for Commissioner Harrington as well, but I understand state leaders were on a call yesterday with the U.S. Department of Labor, trying to understand, I guess, what the latest is with PUA and extended unemployment. Is there going to be a gap, and what do we know so far?
Great question. What we found out yesterday was that there is not going to be a gap, that we will be able to provide for those who are coming off from the unemployment, so there should not be any gap at all. Commissioner Harrington, anything I need to add to that?
No, Governor. What we are doing right now is working with our mainframe team on the legacy system to implement these changes, as well as the vendor that is operating our PUA system. We don't know yet the time frame for implementing all the changes that come with the second or CARES Act extension. But in terms of benefits, folks will not see a lost week, if you will, in benefits from the original CARES Act. As long as they were still eligible and receiving benefits on the weekend in December 26th, they will also receive benefits as long as they're still eligible for the week ending January 2nd.
Which is great news, by the way.
And then maybe just a clarifying question for, I don't know if it's Dr. Levine or Secretary Smith, but Secretary Smith, you mentioned that it's going to be, the next phase is going to be, by age, right? But then, Dr. Levine, you said people with chronic conditions and underlying conditions are going to be prioritized. So I'm wondering, I guess, how those two fit in with each other, I guess.
It's going to, yeah, I'll let them answer, but it's going to be both. Actually, we'll do the age banding, but we want those with chronic conditions to be up front and get to the front of the line, because that's important as well. So they will always have the first in line for that, so that they get the benefit of the vaccine, those with compromised conditions.
Thanks.
Carrie?
Governor, what are your thoughts on the president reluctantly signing the coronavirus relief bill? And what are your thoughts on the $2,000 payments being discussed?
Well, again, I'm grateful that he did finally sign it. I think that it was unfortunate that it took as long as it did, and we were playing a bit of a cruel game with those who would be affected. So again, I'm grateful that he came to the conclusion that it was in the best interest of Americans to sign the bill, and he did so. In terms of the $2,000, we'll have to see how that all works out in Congress. I know, I've been a part of negotiations in the past, and everyone has to give a little bit, as I mentioned in last week's press conference. So I know that they had to come to some agreement to get to a lot of the different provisions within the bill. Again, through the president's urging, it appears now $2,000 is on the table, which is great for Vermont and so forth. But I understand the dilemma it puts many in, because they had to give something up to get that, or they had to give give in to even getting to $600. So it puts people in a tough position, but they'll work it out in Congress.
Thank you.
Governor, or maybe this is better for Secretary Smith, but are there any updates on the correctional facility outbreak there, or the lockdown?
There are no updates other than what was released at 7 o'clock this morning. There's been 2 that have tested positive in Northwest Correctional Facility. The one person was never in the facility why they were infectious, so that's not of concern, but there was one person that had been in the facility during the time of infectious, so there is lockdown. We're going to start staff testing, I believe, tomorrow, and then facility-wide testing, I think, the day after or thereabouts.
Very good. Thank you.
Moving to the phones, we will go to Wilson, the AP.
Happy New Year, everybody. Lots of questions I could ask today, but I'll focus on just one. Governor, it's hard to believe, but next week we're going to be starting the new legislative session. And I'm curious, what are going to be your priorities going into that? And how do you think you'll be able to work with the legislature with the, I guess, a smaller majority than they had in the last session? And I deliberately asked the question very broadly, so answer it as you see fit.
Yeah, well, maybe I can answer it broadly as well. I look forward to the start of the session. This is going to be, again, very unique, remote, and that's going to be difficult for both the legislators and for those who are trying to be part of the process. So hopefully everything that we're doing, talked about today in terms of vaccinations and so forth, will get us to a point where we can go back to somewhat normal, where we can meet in the State House and get to debate some of the issues that Vermonters face. I'm not going to get ahead of what is going to be in the State of the State, which is not that far off. I think it's going to be a week from Thursday. So again, you'll see in a very short period of time what I feel are the priorities and what I feel is the state of the state at this point in time. So again, stay tuned, and we're still trying to unravel some of we'll have a budget address 2 weeks after that, and still trying to unravel what was in the omnibus bill that was passed in Congress as well. But it appears that there are some good things in there that Senator Leahy, Senator Sanders, and Congressman Welch worked on that will benefit Vermont.
Okay, great, thank you.
Eric, the Times Argus.
Yes, this is Leslie for Commissioner Levine. Four Seasons Care Home in Northfield had been on the list of long-term care facilities that were dealing with an outbreak. Is that no longer an active outbreak?
It's still considered an outbreak. However, the limited number of people involved, we suppress the data when it's too small a number.
And I understand earlier this year there was a shortage of flu shot supply. Is that still a problem, or is there plenty of supply now?
I'm actually not aware that there was a problem. The only problem we were aware of was for some of the older than 65 group obtaining the higher potency flu vaccine. That was a transient problem, and literally it's been 4, 5, 6 weeks since I've heard anything about that. So my sense is people are not having trouble accessing that particular flu vaccine, but flu vaccine is still an adequate supply. And I'll build on Commissioner Piechek's slide. There's still opportunities, so please take advantage of those.
Okay, thank you.
Pat, WCAS?
Hi, I'm looking for a little more clarification on how chronic conditions fit into the vaccine strategy. I heard your response to Calvin that you're prioritizing both age and chronic conditions in this, but how do you do both of those simultaneously? So for instance, does someone who is 75 with type 2 diabetes get priority over someone who's 75 with no chronic conditions? Or if someone is 65 and they are immune compromised, do they get bumped up to an earlier age band because of their chronic condition?
Yeah, chronic conditions will be moved to the front of the line, meaning they'll be put into that category. Like when you open up 75 and over or 70 and over, those with chronic conditions in a younger age will be in that banding. So they will always be in the banding. They'll always be a priority. Have that right? Yeah, let's have the real doctor here talk.
There's nothing to do with being a doctor. The reality is it's going to still depend on the amount of vaccine coming into the state at one time. Because you saw with the numbers I presented, there are large numbers of Vermonters who will have chronic conditions and will also be of the appropriate age. So we have the luxury right now of engaging in the planning process to make sure that we get this right. And we will have more to report, as Secretary Smith said in his opening remarks. We'll have more to report as time goes on, because we don't even anticipate being able to get into that phase for at least one more month. Hopefully no longer, but for at least one more month.
Got it. And my next question is likely for you as well. It's kind of logistical then. How is the state going to be notifying people in the next groups when it's their turn for the vaccine? So for instance, if someone is in the 75 plus age group and they hear that now it's their turn, do they reach out to their doctor? Do they wait for their doctor to reach out to them? Do they look for a state vaccination site on their own? I know we're going to get questions about people who are like, well, how do I proceed here?
Yeah, and all that's part of the planning that's going on too, so I don't want to give you the definitive answers, but the reality is there will be abundant traditional media and social media notifications regarding that time frame. Regarding the locations, a lot of people are working with their primary care practices right now anyways, especially in the earlier groups that will go, because those with chronic conditions and higher age generally are more in contact with their primary care on a regular basis, having regular visits, etc. So that will be part of that. Clearly, as you heard, the pharmacies are going to play a role. Our pods, or points of distribution at our local health offices, are going to play a role. And then the opportunities for these mass vaccination situations. I assume, but we haven't worked it out yet, that the registration for those will follow a similar pattern to what we've been using in testing already. But these are details that we will be coming out with over the next month and providing a lot more substance to what I've just said.
Last question, not to be cynical here, but who's checking to see if someone has a chronic condition? You know, like what stops someone from walking up and saying, yeah, I've got diabetes to a vaccination site? Do they have to prove it? Does that doctor's office have to say, yes, this person has that condition?
Yeah, I think the way we've proceeded along for pretty much the whole pandemic has been with expectation of trust and honesty. And, you know, even when we've been asked about enforcing this or enforcing that, if to see if someone's really been doing this or not doing that in terms of quarantine, whatever. We've been, I think, putting a lot of faith at Vermonters, and that process has actually worked if you continue to look at our data. So I don't think we'll be having rigid, enforcement and that kind of thing. But again, details to come later for some of the, aspects of your question.
Thank you.
Lisa, the Valley Reporter.
Good morning. My question is for Dr. Levine, and it's about prophylactic use of monoclonal antibody donations in people who are pre-symptomatic and have with exposure to COVID. There's a test underway in the United Kingdom conducting a randomized controlled trial to determine whether such antibody donations can treat people who have been exposed to a positive person but don't have symptoms yet. And according to the study, it's thought that this protocol could help contain outbreaks and might even offer protection for as long as a year. I know that this is different from how we're currently using monoclonal antibodies for people who have tested positive. What are your thoughts on this protocol or this study?
Yeah, so let me just repeat this so that everyone understands. Monoclonal antibodies are here now in the U.S. They're here in Vermont. Many of our hospitals have had allocations made to them, and we're also storing some when they're not used. They are administered by an intravenous infusion. Their major role at the present time here, not in a study environment, but in practice, is if someone who has mild to moderate symptoms is early enough in their illness and they're at high risk because of a number of criteria for developing more severe illness or even hospitalization, the therapy is ostensibly to prevent the need for hospitalization. There's some animated discussion in the scientific community about that, which I've talked about here, and I won't go any further. What the question that's being asked has to do with actually doing this in somebody who, because of their exposure to someone with COVID and the likelihood that they might themselves develop it, would benefit from use of antibodies. And referencing a study in Great Britain, which I'm not aware of at this time, to actually see if that's true or not. I think there's so much controversy right now with regard to use of these monoclonal antibodies here in the U.S. with a number of expert panels, not saying it's quite ready for prime time, but feeling that they wouldn't say no to use of them, but certainly not as a standard of care. We're waiting for more studies just in that more traditional setting of people who are sick who are getting them as opposed to people who might become sick who are getting them. So I see enough controversy just in our use in the U.S. right now that I can't imagine people entertaining the use of them in a much more preventive fashion, because that would imply even giving them to people who haven't even been exposed, just like a vaccine might be given. And there's certainly no evidence that that would be useful right now. But giving a monoclonal antibody to someone who has been exposed is an interesting hypothesis and I think worthy of study. I will just note that when you look at people in our registry right now, in our database, who have been exposed to a case early in the pandemic, they may have had a 1 in 10 chance of coming down with COVID. Later on, it gets a little higher, maybe 1 in 7 or 1 in 8. Still a lot of opportunity to not get COVID, even though you've been listed as a contact. So it's hard to know where this study will take us. It's going to take them some time, I'm sure, to get results, and we'll look with interest.
Thank you very much, and Happy New Year.
Ed, Newport Daily Express.
Hey, good day. I have two questions. The first one is, we already have 2 vaccines that have been approved for use, and there's others, as I understand it, that are in the pipeline that might be approved sometime in the next few months. Is there any particular vaccine that is better for one particular population, or are they all pretty much generic? And the other question is are you keeping a database to keep track of all the people who get the vaccine?
I think yes to both questions, but Dr. Levine can elaborate on that. I believe one is 16 and over and the other is 18 and over of the approved.
So the second question is easier. We have an immunization registry, so every dose administered is in the registry. And that's going to be critical, of course, for these vaccines that require 2 doses, which are the majority, even the ones in the pipeline. With regard to is one better or another, that's the reason for phase 3 trials. Not only to prove that they're safe and should be administered to a population at large, but to actually determine who might benefit more from one vaccine or another. You're aware that the University of Vermont research community is enrolled in the AstraZeneca trial, and AstraZeneca, I think, preferentially chose a site in Vermont because they wanted to have a little older age demographic. So we're hopeful that that trial, whatever it shows, will have a sufficient number of older individuals, depending on how you define that, whatever cutoff age, so that it has the appropriate power, as we would say, to show effectiveness in that population. And when we look at the 2 vaccines that are out there right now, you know, they were pretty much 95% effective across their study populations. I did note that with the Moderna, as people got a little older, there was a slight decrease in that efficacy. Still very efficacious, but a slight decrease. You have to remember, these are studies that are done with 30, 40,000 people over a several-month period. So we're hopeful that some of these studies that are in the pipeline still will look more effectively at age, will look more effectively at children and teenagers, will look more effectively at some of the chronic conditions that might be at stake here, that one study may have had more people enrolled with one chronic condition than another, and they may look more closely at ethnicity and race, so that we really get a full picture of each vaccine and which ones might, by virtue of the way their study was designed and their enrollment pattern, can shed more light on one population or another.
Okay, great. Thank you, guys. Have a happy New Year.
Thank you.
John, VPR.
Hello. This is also another vaccine question. Secretary Smith referred to this, but I'm looking for a little more detail. How are you going to prioritize people of color and other marginalized communities in the vaccine order of things? How do you reach out to them? Is that through their providers, healthcare providers, et cetera? How do you actually, what are the specifics of reaching out to that community, those communities?
Thanks, John, for the question. This is Mike Smith. First of all, the health department has done a marvelous job during the testing and phase of reaching out to these sort of communities that are out there, and we will continue to do that. We are right now developing what criteria in order to do that. I didn't mention the criteria because we haven't developed it yet. We recognize that is, and I think that's important, by the way, we recognize that that's a community that we have to, because of their disadvantage, because of the inequities that may have happened, because of how COVID has struck some of these communities, that we've got to recognize where they are in the priority and how we bring them into the priority sort of sequencing on this. I don't have any specifics for you because we're still working through those, but it is at the top of our list. It is at the top of our mind of how we reach out to those communities.
Great, and then just a quick question about the elderly and the facilities that have been so hard hit. Is there a plan or some way to, I mean, it's just such a cruel irony that here's the vaccine on the scene while these deaths are going up in these places. Are you looking at, maybe getting to some of these places as quickly as possible where the outbreaks are fierce, or is there sort of a prioritization, if that's the word, within that priority list where you can, maybe put out the fire quickly?
We're trying to put out the fire everywhere, is what we're doing, and we're accelerating. We're trying to accelerate the program as quickly as possible. It's a federal program. It is through the pharmacies that are picked by the federal government, but we've been working with the CDC over the last 24 hours, as well as the pharmacies, and I will say that Kinney's and Walgreens have been very receptive in doing this, in trying to get to the facilities faster than what had originally been planned. And I think you're going to see that over the course of the next few days in terms of what we're trying to do. We already will be to where you've seen the hardest hit are the skilled nursing facilities, and within a week we will have the first dosage in those skilled nursing facilities. Right now we have 19 of them. The remaining will be done within a week, and we should be at least the first dose by next week of the skilled nursing facilities.
Great. Thank you so much.
I just wanted to add one comment to that, and that is people should understand vaccination is not a strategy to end an outbreak in a facility. When a facility has a significant outbreak, and you've seen some of the numbers we've shown on the slides, many people may still be infected but be asymptomatic. So vaccination at that time is usually not the best strategy, other than the usual traditional things we do to control and respond to an outbreak. So it's really to get into what we have to acknowledge is the majority of facilities that don't have outbreaks. And the majority of the assisted livings and residential cares do not have outbreaks. So speedily getting into them before that would ever happen is really the major objective.
I think to reiterate something we talked about maybe a couple of weeks ago in this media briefing was about how long it really does take. So as Dr. Levine had said, from the first moment you get the shot in the arm, it's a month or two before it's truly effective. That's why it's really important for all of us to understand this is going to take some time, and that we must remain vigilant in wearing our masks, keeping socially distanced, and making sure that we don't congregate and travel, because it's going to take a while for us to get vaccines in the arms of those of the most vulnerable. But then it takes, there's a month or two in between where it takes time for it to be truly effective. So this is something we have to think, in terms of months, 4 to 6 months, before we see any real significant light at the end of the tunnel.
Erin BT Digger.
Hi.
Go ahead, Erin.
Yeah, hi. Just to clarify, there was some reference to frontline and essential workers, but just to be clear, frontline workers or essential workers, because I know everybody defines, but let's say teachers, first responders, people who work in retail or high-risk jobs, they're not going to have any prioritization for the next phases. Is that correct?
Yeah, well, this is all age banding, a simple process where we'll be able to communicate that and people will understand. So if any of those folks are in those older age groups, obviously they will come to the forefront. In terms of first responders and so forth, there's some who are in 1A, correct? Right. Maybe Dr. Levine or Secretary Smith can talk about that a bit.
Yeah, our entire EMS workforce about a third of whom have already received the immunization, are in the 1A category.
Okay, thanks for clarifying. So it seems that the state has chosen to kind of prioritize the people who are at highest risk of dying of the virus. But are you concerned at all about people who are at high risk of contracting and potentially spreading the virus in the community? People who work with a lot of other people who have, front-facing jobs, things like that.
Yeah,
I guess that's
that would
kind
be
of
the,
as a
Aaron,
counterbalance for.
Yeah, Aaron, that would be the case regardless of how we do this, whether if you did it by essential worker, those may not be front-facing, they may not be in connection with a lot of people. So regardless of how we do that, that's still a concern from my standpoint, and I believe from all our standpoints, that that's why we keep talking about the need to continue to wear our masks and do all the things that we've been doing over the last 10 months, because it still is important over the next 6 months as it was 6 months ago, until we get through this. And we're fortunate to have this vaccine here today, because many of us, as I talked about in the last press briefing, none of us expected this to be here this soon. And so we're fortunate to have it here, and that we're able to vaccinate, and we've vaccinated about 10,000 Vermonters thus far, and look forward to distributing the vaccine to as many as possible over the next few months, depending on the supply that comes to us, and we'll distribute it just as fast as we can. Anything to add to that, Dr. Levine or Secretary Smith? No. Okay.
Joe, Barton Chronicle.
I'm guessing this is a question for Dr. Levine. The focus in many of the figures, understandably enough, has been on deaths caused by COVID. But my understanding is that some people who contract the disease have long-lasting and severe results from that. I'm wondering whether, as time has gone by, there is sufficient information to get some sense of what percentage of people are affected in that way, and how long those more severe effects might last.
Yeah, thanks for the question, Joe. We've addressed this sporadically, and I wish I had more information to give this time than I did the last time, but this is a evolving situation. You're referring to chronic symptoms, which means symptoms that are still present 3 or 4 months after you came down with the illness in the first place. And these chronic symptoms are very variable person to person. They can be chronic fatigue. They can be sort of emotional and mental status changes. They can be cardiac. They can be related to shortness of breath in the lungs. There's a whole variety of them. Our understanding of them, unfortunately, is not great. And I say our, meaning the scientific community, not Vermont. The outlier rate, if you will, the highest rate that's being reported is up to 10% of people who've come down with COVID. It could be less. We have no idea, really. We are actually on the, I don't want to say quite on the precipice, but we're very close to embarking on our own study, looking now that we have 7,000 people who have become positive tests and cases, looking at some of them, and it'll take a lot of interviewing, and it'll take some time, but it will actually help us shed light on how people who fit in what we call that recovered category really look. Are they really recovered? Are they having some symptoms that they are debilitated by in their future? I've chosen to treat them very seriously and really regard them as very important because, you know, nationally and internationally, there's some tendency at times to underestimate what getting COVID means. And I certainly don't want to subscribe to that. I believe people who get it, even when they resolve their symptoms, often tell you about some genuine discomfort and how badly they felt. So I can only imagine for those who may have symptoms that go longer than 3 or 4 months, how they feel. So I think we need to take it seriously. I do agree with you that it's something we'd want to prevent, and that we would hope a vaccine will prevent, since the vaccine, as we know it, is preventing people from becoming symptomatic with COVID due to the antibodies that they formed as a result of getting the vaccine. So we should see less of this kind of a syndrome in a post-vaccine era if enough of the population takes the vaccine. So stay tuned is all I can tell you, because this so-called long hauler syndrome is not as well delineated as we'd like it to be yet, and we're going to need to watch it closely.
Thank you.
Tom, the Vermont Standard.
Good afternoon, everyone. My question, I assume, is for either Secretary Smith or Dr. Levine. You've referenced the 19 skilled nursing facilities in the state that have already received the vaccine, and I'm wondering if there is a publicly available listing of those facilities and of the remaining 18 or so that are expected to receive the vaccine next week.
Secretary Smith.
Tom, thank you for the question. We can make available for you that schedule. I think the Department of Aging and Independent Living has that schedule. I will make sure. I was curious to learn that one of the facilities in Woodstock was the one facility that I said would, when I said, in fact, by January 8th, we should be finished with providing the first dose of vaccine to all but one of the residents of skilled nursing facilities. That one residence is in Woodstock, so I just wanted you to be aware of that, and we will find the list for you.
That'd be great. Can you tell us why that? Can you explain why that one facility might be the outlier?
As you know, I'm a subscriber of the Vermont Standard, and also that's my hometown, so I pay particular attention to that. I asked that question this morning when I noticed it on the list. I don't have the information for you.
Okay. And then the follow-up question, I'm assuming that the assisted living facilities will be next in line after the skilled nursing facilities are taken care of. Is that accurate?
Assisted and residential care facilities, both of them together.
Excellent. All right, thank you very much.
And there's just one correction, Steve, that I'd like to make. We're starting the employee testing at Northwest today, and tomorrow we're doing the facility-wide testing with the inmates.
Pam Davis, a Vermont Journal.
Just a first question for Mike Smith. I think that the information that you folks have given out today is really the most complete that I've heard, and I'd just like to harass Mike Smith one step further and wonder whether he's has been able to chunk out the population in terms of numbers and compare that to the likely inflow of vaccines to see whether, so that people could get some sense of whether, where they sort of stand in the chance to get it. The level, the tier 1 people look really great. I mean, but they're all contained in hospitals and nursing homes and so forth. As soon as you get to the second level which is out at 75 plus, people are all over the place. And I'm just curious whether Mike Smith could just take one more step and just speculate whether you've been able to predict the rate at which this whole thing would move if the level of vaccine that comes in continues to be what we've seen so far.
Yeah, if it dribbles in, Ham, it is going to take a while. If it comes in like we think it's going to become, it's exponentially going to be increasing as manufacturers get up to speed and as other vaccines possibly come online, then it's going to take it's going to be faster. What I think have I chunked out sort of those segments? Those are easily chunked out. But I don't think, I know we've done it. I just don't have it off the top of my head of what the band 75 plus looks like, what the age band 70 to 75 looks like. I haven't chunked all that out.
Just a quick follow-up on that. Thank you. Have you speculated about, and do you have a sort of a professional opinion about the extent to which the given tranche of a vaccine is going to would go further than anticipated because some people won't accept them?
Yeah, we are. Here's how we plan. We plan that everybody's going to accept it, realizing that there are folks that aren't going to accept it, but we plan that everybody is going to accept it.
And we'll just see it. Thank you. I just got one final question. I think I've asked this before, but I'm still uncertain about it. The two main vaccines so far are considered to be in the low 90s for effectiveness. I'm just not certain about what the circumstance is in the way the vaccine actually behaves when it deals with the virus. What happens when what happens to the 5 to 7% of the population that get a vaccine, but the vaccine does not work? And I just wonder, like, what Dr. Levine thinks about that, and I'm curious. I still wonder whether it makes sense, if it's doable, to use serum tests to find out whether the vaccine has actually generated the antibody.
Yeah, so the company's studies results would indicate it's mid-90s%, like 94, 95%. But still, to get to your question, if you have enough of the population either previously infected or immunized, the hope is that the degree of viral suppression will be low, will be significant, so that the amount of virus around will be very low, and that even those people who may not have had the kind of immune response to the vaccine that we want still will have less and less chance of encountering the virus. Or perhaps they may not have mounted the best immune response, but it might be sufficient to reduce the severity of whatever illness they might get. We'll just have to see how that kind of thing plays out in the future, and certainly look at what percent of the population has taken the vaccine or been previously ill from the virus. Again, we don't know much about the duration of the immune response either, because these are all very new vaccines, but our hope is that they will be for the long term and not require any boosters or things of that sort.
Well, I'm inferring from that, Dr. Levine, that you just don't think it's a valid track to look at as to whether you're going to use this, whether it makes sense to use a serum test. You think that just doesn't work? Because for an individual, what will happen, almost certain to happen, is that once people get the vaccine, I bet you this will happen, it's already starting to happen. As soon as they get the vaccine, they're going to, inevitably, some of them are going to be less rigid and careful about how they behave. They're going to start thinking that they're not going to get the virus. That's what I'm curious about.
Yeah, no, I get it. So the bottom line would be, number one, we are still letting everyone in the population know that the era of masks and distancing doesn't end just because Group 1A is getting their vaccine. It's going to take a long time till we can get rid of our masks in terms of our behavior. Number two, if we did an antibody test on everybody, one thing you're leading to in your question is there's a qualitative test which just says, yes, you have antibody, but then there's more of a quantitative test to see actually how sufficient your immune response is, and that's different. Number three is the notion of a vaccine passport, which the CDC has been talking about and prepared to really make sure that the population who have been vaccinated have some kind of evidence that they indeed got their 2 shots, if it's a 2-shot vaccine, and could ostensibly be somewhat immune to COVID-19. I'm not sure the expense of doing antibody testing on the entire population after you've invested in the expense of managing the whole pandemic and giving everybody a vaccine is justified at that point in time, knowing that hopefully the general population will behave somewhat similar to the study population and have a pretty good response to the vaccine.
Okay, we're going to move to...
Thank you.
Thanks, Ann. We're going to move to Avery at WCAX.
Hi, my question is for Governor Scott and Secretary French. So Newberry is voting to pull out of the Oxbow Unified Union School District, and then several other communities, at least 3, are holding similar votes in the coming weeks. Just wanted to get your reaction to that and whether you see it as a sign of the state's effort to force these communities to merge isn't working.
I'll let Secretary French respond to that one.
Yeah, thank you, Governor. Yeah, I think, Act 46 has certainly been very challenging for a number of districts, to navigate. I think, in the case of Halifax and Reedsboro, which I think were the first 2 to approach the state board on unmerging, the state board realized it probably didn't have adequate tools to review these kinds of requests because the statutory language around that aspect hasn't really been updated when Act 46 was updated. So the state board is asking the General Assembly to take a look at the issue. That remains to be seen how that ultimately will play out. But I think it's indicative of how challenging some of these decisions have been for communities.
Do you see it as, just kind of going back to my follow-up question, do you see it as it's not, the effort's not working?
I think it's more, it being challenging. Some of the underlying conditions that, ultimately brought Act 46 into being, such as, declining demographics and increased costs, those issues are not going away. So, I mean, once again, it's very challenging in some communities to realize the goals of Act 46, and, I guess we're not surprised to a certain extent that we're seeing some of these issues being brought forward.
Okay, thank you.
Jolie, Local 22.
Hi, I'm curious to know, do those in priority group 1A need to receive their second dose before the state goes on to vaccinate group 1B, so on and so forth?
I'd let Dr. Levine or Secretary Smith, I don't believe so, but.
The answer is no, and especially because many in priority group 1A will have received their first dose somewhere towards the middle of January, and they wouldn't be eligible for their second dose till February. And if we are optimistic, we're going to see vaccine beyond group 1A come into the state late January, early February. I don't want to overpromise here, but that's sort of a timeline that we would like to be optimistic about. And that's really going to go with every phase. So you look at the number of appointments that are made, et cetera. So let's say we have the over 75 age group and there's more vaccine available than there are appointments scheduled. We wouldn't want to make the 70 to 75-year age group wait longer than they would have to. The goal here is to get the vaccine to the population as quickly as possible. So at any phase of development over the next number of months, we just need to look at the dashboard that was showed and look at the data and make sure that there are sufficient people in the group that's currently eligible to get the vaccine scheduled to get it. And if there's room, move the next group in.
Thank you. I also wanted to ask Governor Scott, do you have any concerns for people going out to restaurants on New Year's Eve? And are there increased guidelines for restaurants?
Yeah, you know, we've adhered to some pretty strict guidelines in terms of our restaurants. What we're not advocating is for multi-family groups to get together. Actually, we believe that they would be safer in a restaurant where there's 50% capacity, where a single household is seated at a table and they're spaced apart. So my biggest concern is those, again, larger gatherings with multiple families and individuals getting together to celebrate New Year's Eve. I would advocate let's let 2021 come in without a lot of noise, and let's get on to 2021 and what we can look at in the future after COVID. But let's let COVID subside in 2020 without a lot of fanfare.
Thank you.
I'm sorry, just seeing Secretary Curley wanted to just outline the specific restaurant measures that are in place.
Sure. Commissioner, or Secretary Curley, do you want to go over some of the guidelines for restaurants?
Actually, Governor, I think you handled it really well. Just as a reminder to folks, bars are closed anyway. Bar seating with proper barriers are still open. And again, as you mentioned, properly spaced in a restaurant, dining with your family is encouraged over a group party. Restaurants are asked to close at 10. But beyond that, I think you hit it all.
Okay. Yeah, thank you very much for that reminder.
Tim, Vermont Business Magazine.
Hi, Governor. I had a couple of questions about the Public Utilities Commission that you're looking for a new member. I assume this is Commissioner Hoffman's position here. You're looking for application. And I'm wondering two things. One, are you looking to go in a different direction with the PUC? And more broadly, philosophically, do you have an issue, as other elected officials have, with this basically a fourth branch of government? The PUC has tremendous power, that's unelectable power. And so on those two questions, do you have a direction, and what do you think philosophically about that?
Yeah, I think in terms of appointing a member, Sarah Hoffman has given us notice that she will not be seeking to be reappointed, so that opens up the seat. And I'm looking for someone who's moderate, who has an understanding of the dynamics of Vermont, that shares some of my values in terms of public service. And we outlined those in the letter that we're hoping for a number of people that will come forward so that we have a broad selection, a pool to choose from. So again, just having the right temperament, having the right attitude, and having the 4 C's that I talk about a lot, and that's really important to me, character and integrity, competence, commitment to the job ahead, and commitment to Vermont, and some of my thoughts about Vermont. So all those added together, I look forward to a broad pool of candidates.
How about the philosophical question about the commission itself, whether it has basically too much power?
Well, again, having the commission having a lot of power, and then putting people on that understand that they have to be answerable as well to the people. I think that's important, and your attitude about utilizing that power, I think, is as important as anything else.
So you're not, I've never heard you say this, but you wouldn't advocate for disbanding the commission?
No.
Rolling those regulatory powers in the administration?
Yeah, no, I think just making sure that you have the right people on the commission is important.
All right, great, thank you.
Guy Page?
Governor, I want to pick up on Tim's question, a little bit more specific perhaps. The Public Utilities Commission has been drilling down a lot on reducing the per kilowatt cost of solar power, net metering subsidies, fulfilling its role in keeping energy prices down. Do you expect that your appointee would continue in that practice?
Well, again, Guy, as I said before, I'm looking for someone with the 4 C's that I surround myself with teammates that adhere to that, and one of them is commitment to my vision, and the affordability of Vermont is a problem for us. Something that we have to keep in mind every single day in all different areas. So it's no different here. That I just had an appreciation for trying to attract more people into the state, trying to keep more businesses here, and trying to address the affordability challenges that we have and we face today. And we faced pre-pandemic, and we're going to face after we have relief from the pandemic as well.
My second question is about the marijuana board. There was supposed to be appointees by, I believe it was November 4th, you called for another round of candidates. Were you unhappy with those that were sent to you? Why have you asked for another round of candidates for that?
I don't know as we asked for another round of candidates. I haven't been through it's just one pool at this point. We wanted to make sure that we got as broad a spectrum as possible at this point. So I don't think we haven't rejected anybody at this point. We're just asking for a pool of candidates.
Okay. Any timeline for when people would be appointed?
I don't have that at my fingertips, and I'm not sure if it's prescribed, but we want to get them appointed just as quick as we possibly can.
Okay, thank you.
Greg, the County Courier?
Good morning, Governor. I think 3 quick questions, if I could, since I skipped on Thursday. Starting out with...
You don't get a bank, Greg. You had 6 questions like 2 weeks ago, so... Oh, go ahead. That's fine.
I wasn't keeping track, I guess, 2 weeks ago. All right. Starting out with the correctional center in St. Albans with a couple employees testing positive. I'm wondering if the state is using rapid antigen testing for employees on a daily or at least on a regular basis.
I don't believe we are. I think we're...
And if not, why?
Yeah. Secretary Smith.
Greg, we've accelerated our testing for staff at correctional facilities. I believe it's weekly for staff, weekly with PCR testing. We aren't using antigen testing at those facilities. We've been very successful in finding cases with the current method that we had. As you know, we're on a rotating schedule at each facility, doing a facility-wide testing on a random basis. That includes Mississippi, by the way, and we do that on a regular basis. So each week we're doing facility-wide testing at the various facilities that we do have, and we rotate facility to facility, and on a weekly basis we do staff testing.
Okay. Governor, on the topic of correctional facilities, last week there was a Downs-Racklin-Martin report that was released, and in that report it suggested several solutions to some problems, but 2 of which are issuing body cameras to every correctional officer, as well as building a new women's facility. During that press release, Secretary Smith said that he wanted to see a new facility and see body cameras issued to everybody and suggested that it should be funded without using bonded money. Are you on board with making sure that this year's budget has money for both of those commitments?
Yeah, but first of all, I don't want to get ahead of our priorities and our budget and so forth. As you might recall, I think it was 3 years ago, we had approached the legislature with a plan to move forward with updating our facilities, and we still believe that's the case. We need to upgrade and do something different than we're doing today. In terms of the body cameras, we think it's a good idea for a number of those folks both in the correctional facilities, but more broadly amongst the enforcement community at large. So we're going to move forward as quickly as we possibly can, depending on our resources. I did want to go back, and I may have Secretary Smith comment further on that, but I want to go back to the other question you had on the antigen testing, because we don't have an unlimited supply of antigen testing supplies at this point. So I think it's important to understand that we've reserved that for our long-term care facilities so that we can continue to administer those tests in those facilities, which we think are the most vulnerable. So I don't know if Dr. Levine wanted to answer any further on that, just so we're clear.
Yeah, I mean, we have one of the most aggressive testing protocols in the country using the antigen cards. And they did come from the federal government, and we appreciate them very much, but they are having issues with production on the production end, and we're still getting our supply in, but they will not last forever when you're using them on such an aggressive testing protocol. So we want to continue to reserve them in the setting they're being used very effectively, and I couldn't imagine we'd have the ability to distribute them more widely, such as to correctional facilities. But as was pointed out, the track record has been excellent in the correctional facilities using the protocols we use.
Hey, Greg, can I?
Dr. Levine, and while you're...
Yeah, Greg, can I just go back, because I want to make sure that you understood my answer from a week ago on the question of a new facility and body cams. I thought you were referring to what sort of money you would be using to fund the body cams. I said general fund. What we would be using to build a new facility would obviously go through the capital budget, and there is money to look at some of those aspects, or there has been money in the capital budget to look at some of those aspects of a woman's facility. So just to clarify, if we were going to build a new facility, it would be in the capital budget, and the capital budget is funded by bonded money.
Okay, thank you for that clarification, Secretary. Dr. Levine, lastly, with all eyes on vaccines, the state has put up a vaccine dashboard, apparently updated weekly. Are those numbers not tallied anywhere in state government on a daily basis? And if so, why is it not possible to get those out in a more timely manner, like in the COVID dashboard?
Yeah, Greg, this is Mike Smith again. I'm just going to steal some of Dr. Levine's time. We are anticipating that we're going to be updating that on a more frequent basis, and we'll have more to say about that in the next day or two.
Okay, thank you. And that's it for me. Thanks for indulging me with that extra question, Governor. You have a great day.
Welcome.
Mike Donahue, the Islander.
Thanks, Rebecca.
Unfortunately, Mike, I gave Greg your question, so.
I'll try to limit mine to 5.
Okay.
One follow-up for Dr. Levine. We had asked for the updated list of outbreaks last week. We yet to receive that list, and yesterday actually we were told by your office that we now need to file a formal Vermont Public Records request by your staff in order to respond, and I'm just wondering why the change in transparency, why not be forthcoming like you were earlier,
when we got the list?
Not a change of transparency at all. It's a respect for our observation of HIPAA and our observation of privacy requirements, and making sure that all of those issues are vetted without us just sending a list. They're vetted by our legal counsel team. So we needed to put it through this extra process.
So every question going to the health department going forward will now require a formal Vermont public records request.
Not true, but for these types of outbreaks, especially when an outbreak can be defined essentially in some settings by 1 or 2 cases, we need to exercise that due diligence.
Okay. Today, you had mentioned the state is monitoring the distribution of the vaccine. We got a call from a Southern Vermont reader on Saturday about one of the pharmacies failing to show up to provide vaccines at a site. I think it's 75 units, living units, and they were waiting several hours, and the pharmacy was a no-show. I'm just wondering, how many no-shows have you received reports on?
Secretary Smith has a piece of paper in his hand, and I think can answer that question.
Mike, actually, the piece of paper I have in my hand is on corrections. We are not running the skilled nursing residential care or the assisted living program. That's the federal government through the various pharmacies. This is the first that I've heard about that. If that is true, I'd like to get the name of that facility. I will reach out to you later.
Okay, good. And while you're there, could you clarify the 1A group? It sounds like once that priority group is done, that the CDC's priority 1B, 1C, whatever, will not be followed, but rather it will be strictly age banding that includes those with chronic conditions. Are 1B and 1C, are they sort of fallen by the wayside? Can you clarify that?
Yeah, I think what I would rather say is after 1A, we go to what is called the mass vaccination program. The 1B, the 1C, those sort of things are, from our perspective, are just too difficult to implement in a way that is fair, in a way that gets to our prime objective, which is saving lives, and secondly, which is understandable to Vermonters. With the, so we've gone to the age banding after 1A, age banding, 75 plus, over 70, over 65, those sort of things in 5-year increments, and then put in as well as priority those people that have been disadvantaged and those people who have chronic conditions. So you're absolutely right. We have decided to go in a different direction than maybe some others have. We often have said this at the podium. We learn from others. We'll see how it goes. If there's corrections that need to be made, we'll make corrections and look at other states. But we think this is the fairest way. We think this is the most understandable way. We think this is the easiest to administer, and it runs right up to our primary objective, which is saving lives.
Great. Thanks, Mike, as always. Appreciate it. Thank you.
Andrew, Caledonian Record.
Yes, thank you. Good afternoon. Secretary Smith mentioned earlier that you guys are going to work your plans for vaccinations based on the assumption that everyone is going to be interested in receiving it. I'm wondering, is it too soon to know yet what the actual uptake percentage is? Are you getting, and perhaps this would be best for Dr. Levine, are you hearing of any data that suggests a certain percentage is receiving it at the healthcare level and the long-term care level at this point?
Yeah, so I can't give you a specific number. We have not done a population-wide survey of the whole state. The surveys I'm aware of were done by individual hospitals across the state, and they were done kind of sequentially, so we know where they were a month and a half ago, where they were 2 weeks ago. And we've seen increases in their healthcare workforce voicing that they would take the vaccine. Started in the 50-50 range, inched its way up. Some places it was 70 to 80% last time I spoke with the hospitals across the state. And if we think that healthcare workers being in the health field might be more critical in their appraisal of the vaccine, then they would be even harder to convince. And if the numbers are clearly going in that direction, I think that bodes well for the general population as well. I wanted to add one more thing to what Secretary Smith was saying about the priority groups and what have you. If you look carefully at what the Advisory Council on Immunization Practices said in their release of their recommendations, much of what you've heard this morning is in Priority Group 1B and Priority Group 1C. So it's not to say there was a line in the sand drawn and we're in one place in a very polarized direction away from that. There's a tremendous amount of commonality there, with the addition of some feasibility and practicality as well. And I want to remind people that we're still waiting to hear from our own advisory council, which we hope to hear tomorrow, who may have their own angle on things, and obviously we're going to take that under consideration and see how their proposals look as well. But these are all recommendations. So the CDC's ACIP is a recommendation. It's not a do it this way or you don't get vaccine. So I want to be very clear about that.
Okay, thank you. And perhaps a quick one for the governor, sports related. I asked last week about the introduction of games. This week, a slightly different question. What do you need to see to happen to lift some of the number of participant restrictions? Right now, indoor activities are limited to 25 people unless distinct spaces can be created, which is smaller than where sports were before, I think. So what do you need to see in cases in order for that number to rise up a little?
Well, again, I think we need to get through what we perceive could be a bit of an increase due to the holidays, but we'll get through that first before we make any decisions on any changes to the sports guidance. But we'll do it as quick as we possibly can. We'd like to see our youth playing games as soon as possible and expanding in terms of everyone getting some recreation.
Okay, thank you, everyone.
Matthew Roy, 7 days.
Hi, good afternoon. This question is for Dr. Levine. Doctor, now that several thousand Vermonters have been vaccinated, what can you say about any potential adverse reactions? Are any being reported? And if so, can you describe their nature?
Yes, so there's several levels of adverse reactions, and the common ones, like pain at the injection site, mild fatigue, things of that sort, would be expected. I have not yet heard the results of the initial vaccinations, having been in such a short time frame, but users of the electronic systems at hand are encouraged to actually report these. So there's a vaccine administration, vaccine adverse event reporting system, which healthcare providers and others can enter data into. People can have the opportunity to go onto a website on their own initially and report things as well. I've not heard of any of that data at this point in time. The next level, which is the most important thing, which we would have heard of, is would there have been any anaphylactic reactions? I am aware of, the ones that have been publicized in the news nationwide and internationally. I know for a fact that with the Pfizer vaccine, the state of Maine, on its first few administrations, had 2 anaphylactic reactions. I know that Massachusetts had either 1 or 2 with the Moderna. So these are real, but again, these are small numbers in a percentage-wise, and usually seen in people who have had a prior reaction of some kind of allergic reaction or even anaphylaxis to vaccines or their ingredients. So those are the things we want to watch the most closely. And to protect safety, we want to make sure that all of the mechanisms we've designed to administer the vaccine, whether it be in a mass vac site, whether it be in a pharmacy or in a doctor's office, all have the capability of observing the patient for the appropriate amount of time, which is 15 or 30 minutes, depending on having a history of reactions or not, and administer the necessary treatment if such a reaction occurred.
Thank you.
Steve, NEK-TV?
Hi, can you hear me?
We can.
Great, thank you very much. I had a question from a viewer for Dr. Levine, if I may. Doctor, you said that the ICU beds were being used for isolation versus critical care. And if the case count has doubled, why do you think we still have the low state ICU and hospitalization rates? And what is our ICU capacity and normal utilization rate?
Yeah, so just from the front here, the ICU is only in 1 or 2 hospitals, or is that being used as a more or less isolation setting? And the other hospitals, if you're in the ICU, it's because you actually needed all of the services you would get in an ICU. So, you know, a half a dozen or less people in an ICU environment in Vermont is but a fraction of all the ICU beds available. We hear this reported several times a week when we have our State Emergency Operations Center and Health Operations Center meetings. The Healthcare Coalition constantly reports to us how many ICU beds are still available, how many hospital beds are still available. And as I don't think Commissioner Pichek showed it this time, but many times he's shown the data that clearly show us to be below the bar, if you will, for where we would worry about access to those beds being an issue. Why we're seeing less people, you know, we're still seeing sufficient people in the hospital, and a small percentage of those in an ICU. There's clearly management changes that have occurred in COVID over the course of the pandemic, where we've improved our ability to do a lot of the early interventions that would prevent someone from needing to escalate their care to an ICU environment. I've also noticed, and this is a bit, I don't like to be anecdotal from a health department point of view, but in scanning the nightly reports of who's tested positive in the state, we still have elderly people being reported, but we have a lot more younger people being reported as well. And some of that's going to be a little bit biased by, are we having an outbreak in a long-term care facility or not? And as I indicated earlier, we have many outbreaks in long-term care, but they're being followed over a long period of time. We're not seeing all of a sudden 100 new cases in one setting or another to bias our data to an older population. So because those are kind of stable, we're seeing a younger element in the statistics. So they are, by nature, less likely to have their case escalate to the need for hospitalization or critical care. Does that answer your question, Steve?
Yeah, that's great. Could I have one for the governor, please, if I may?
I think so. He's approaching the podium.
Great, thank you very much. Governor, regarding our unemployment insurance computer system, this thing has been like a coal-fired wheezing machine that we only have one person who understands the COBOL language that's needed to like program or update the thing. and we've known this for years and years. Are we gonna try and maybe put some pressure on the legislature to maybe update the old coal-fired coal ball machine?
Steve, I couldn't have said it better than you said it. We might bring you in to have you testify on this, actually. We've advocated for some changes for years. Unfortunately, the legislature has not taken advantage of that, and I understand it. I mean, we came pre-pandemic, we had the lowest unemployment rate in the country. We had 2,000 or 3,000 people on unemployment, and then almost overnight went to 90,000, and it did challenge us. It's a 50-year-old relic, and it needs to be updated and upgraded. But we're not alone in that either. There are a number of other states that are in the exact same position we are. So I'm hopeful we'll receive federal help on a wide-scale basis to help replace the system that is in desperate need. So yes, we'll be talking with the legislature about that. I think everyone understands the need at this point. It certainly highlighted the challenges that we face in that department.
All right, great. Thank you both very much.
That's it. All right. Well, again, we'll see you on Thursday, not Friday, because of New Year's and New Year's Eve. So same time, same place, different day. Thank you.